we'll discuss how to choose between risk ratio, odds ratio, or risk difference, or a standardized mean difference. When do you choose which measure to do a meta-analysis? Because the software will give you a choice, and you have to choose one of those, and that is totally your choice, and that choice has to be made based on some understanding of rationale, which one to choose when. So, many people here now are engaged in doing meta-analysis. Many have published also. So, this is something which you need to know, because software will not do it for you. You will have to do it. And if you remember, we a long time ago we have discussed this, that when you do meta-analysis, you basically take out average. But this average is not simple average. What kind of average is this? Weighted average. So you have to give weight based on certain criteria. And in a situation when there is dichotomous outcome, binary outcome, as we call it, then weights are given according to not only number of subjects in the study, but also number of events. So number of events is an important component of determining weight, not only sample size. Because if events are 0, obviously weight will be much less compared to events when there are hundreds or thousands. So number of events and sample size together are combined in a formula, and that is called inverse variance formula. So variance is calculated and inverse of that is taken, and that is usually the weight which is assigned to different studies while you are calculating. So when you calculate weighted average, if you remember, I had shown a situation in which students had obtained different marks in written, verbal, and practical. And when they were very similar, some patterns were very similar, some were very dissimilar. So, anyone remembers when did you find it comfortable, or let's say acceptable? Some people, some patterns had something like 55%, 50%, 45% in various components. And the other pattern was where there was 90% in theory, but only 10% in practical, and 15% in oral. So like that, 4 patterns I had shown. So you don't remember that, right? Students' Union had complained to the dean that there has been problem in the exam. Some good students have failed. You don't remember that story? It vanishes very quickly. So essentially, I had shown 2 patterns where marks were similar, 60, 55, 50, something like this. Also 30, 35, 40, something like this, which was for those who failed and for those who passed. But some who passed had only 15 marks in theory, but 80 and 75 in practical and viva, right? So when the marks were very, or let's say in 2 of the patterns, marks were very dissimilar, and 2 patterns had very similar. when I asked where are you concerned, then everybody was raising hand uh, about having concerns where, when the marks were dissimilar. Because when it is dissimilar, when the numbers are very widely varying, 90 or 85 and 10 and 15, or 15 and 85 and 75, that kind of difference makes you uncomfortable, because there may be many reasons why they were different, right? So that, so you should keep in mind that when we are combining data, then more similar they look, the better, right? And after all, when you have these numbers of different trials are there, and in one trial, suppose 15% have mortality in treatment arm and 20% in the control arm. From these two figures, 15% and 20%, you convert them into various ways of expressing effect. One is, you can just simply take a difference and say 5% difference. That is what is called risk difference. But you also remember that we did division, 15% divided by 20%, which was, anybody remembers, which was called what? Risk ratio. Because risk in the treatment arm divided by risk in the control arm. So, what I mean is, you can take ratio, but you can take difference. So, difference measures are there, and ratio measures are there. So, these are the two kinds of measures. And after all, you are basically converting from 15% and 20%, which you have observed, into different expressions. So when you convert, there are many ways of converting. So in this case, difference, risk ratio, odds ratio, number needed to treat, these are all, you can say, different ways of expressing the same effect. You could simply say that 15% people died in treatment arm and 20% in control arm. But instead of saying this, now you are saying slightly differently, that there is the risk difference of 5%, now there is a risk ratio of 0.75, and so on. So, when you are choosing between these, risk difference or risk ratio or odds ratio, question you have to ask is, which one will make these results look similar? Remember, similarity is the source of comfort. You are comfortable, you find it acceptable if these various studies give similar figures. Because then only taking out average makes you feel comfortable, because that is appears to be capturing the essence of what you see across the components which you are taking into average. That is the point you have to keep in mind. That because meta-analysis is weighted average, average is meaningful and acceptable if there are similarity in the figures which you are combining into an average. So you should ask one criteria which is taken to select the effect measure in dichotomous outcomes between risk difference, risk ratio, odds ratio. There are some other ratios and differences also, but is which one will look similar across the study. That is one criteria. So, similarity gives comfort. Similarity is acceptable. That is why you want to, since you are converting those 15% and 20% figures into different study results, you have to see which one, whether the difference or the risk ratio or the odds ratio will give similar looking figures. Right? Because ultimately, you are going to take out average. And average makes sense or makes you comfortable or is acceptable when the components look similar, right? So, you can have figures like 10, 100, 1,000, 10,000. Are they similar or dissimilar? Dissimilar, very dissimilar, no? 10, 100, 1,000, 10,000, right? Very dissimilar. But if you take, convert that in logarithmic scale, then that will become 1, 2, 3, and 4. Which one is more similar? 1, 2, 3, 4 or 10, 100, 1,000, and 10,000? 1, 2, 3, 4. So the idea is that you should use such expression which will make the results across the studies look similar, right? So that is one criteria which is to be taken when you are choosing a effect measure in dichotomous outcome. Second, similar looking figures, right? Similar looking figures, not the outcome. Outcome may be like 10, 100, 1,000, 10,000. But we can convert that into 1, 2, 3, 4. It will look similar, right? So convert it in a way which makes it look similar. Then you combine, it becomes more acceptable, more meaningful, more comfortable, right? Second criteria which we use is it should allow you easy calculation of average. After all, you are doing it to calculate average. Every meta-analysis ultimately leads to bringing out average, taking out average. So whichever allows that calculation, that should be accepted, isn't it? That is not only calculating one point, but you have to calculate confidence interval also. So you should choose a measure which will be mathematically suitable to calculate average. So it should have properties, it should have mathematical properties, statistical properties, which will allow calculation of average, because average is one of the aim of doing meta-analysis, right? And the third criteria which we use is this should be understandable to the audience, to the stakeholders, in this case to the clinicians. So when you combine the results and you tell them, they should be able to follow it, they should be able to understand it. So these are the criteria. So again, it depends on what are you combining. If you are combining prevalence, then you have to use proportions, and then you have to use some kind of transformation. Like, as I told you, 10, 100, 1,000, 10,000, you transform it to 1, 2, 3, 4, but just by taking logarithmic transformation. So you have to transform that. That is called a slightly different kind of transformation in prevalence, arc sign transformation. But you have to do transformation so that it has certain properties, like similarity is one such property. If you are doing diagnostic test study meta-analysis, then you may have to take sensitivity specificity or area under ROC curve. If you are going to do for case control study, you may have to only take odds ratio. If you do cohort study or randomized trials, then depending on whether the outcome is continuous or dichotomous or time to event, you remember these three types of outcomes we discussed the other day. So depending on the outcome, you have to choose whether it's mean difference, standardized mean difference, for continuous, you have to choose between risk difference, odds ratio, risk ratio in dichotomous, and in time to event, it will be hazard difference or hazard ratio. So you have to make choices. We are going to discuss mostly about randomized control trial. A prognosis is like cohort study. So again, you express it into risk ratio or odds ratio. So I have already said that it depends on what you are, what type of effect measure or what type of scale you are using, dichotomous or continuous, and counts and rates, counting like it will be number of epileptic events experienced by an individual, right? Number of exacerbations experienced by a person of depression, or number of recurrences experienced by a patient of malaria, for example. So those are called counts and rates. And then time to event, when there is, let's say, interest in looking at what time the event is taking place, not only the fact of occurrence of event. So most of the time you will have dichotomous outcome. I give you one example, like we did a meta-analysis in 2021, which we published Neurology USA Journal. And I think told you about this, that we registered with only RIMS people. Later on, we had a lot of WHO people joined. And when WHO people had joined, then people from UK, from USA, from Canada, from some European countries, they all joined in this meta-analysis. So actually, if you start a good work, you will find a lot of people who will come and join you. And this was done on prevalence of stroke. So we had to take transformation of that prevalence or proportion. That is fortunately available in this software. No, this is also possible because we had hundreds of references. It's not given here, more than 300. Then it becomes difficult. Sometimes same authors has published in multiple times. So you can give reference like this. It depends on the software also. What does it allow? Then for binary outcome or dichotomous outcome, a ratio measure is preferred. Why is it preferred? Because it tends to give similar figures across the study. So it maximizes what we call homogeneity. But it is not for the purpose of fulfilling statistical requirement that we do it. We do it because that tends to remain relatively constant across the subgroups of patients. Therefore, when you apply it to individual patient, it will probably belong to a group where the effect will be same as you have found in meta-analysis when you calculated the average. So that is what we call so that is a problem with you can say mostly with non or observational studies. Randomized trials, they don't adjust very often. So that is why randomized trials are much more popular for doing meta-analysis. Anyway, so the ratio measures are consistent across different strata, across different subgroups of patients. So we prefer a ratio measure. Difference gives more heterogeneity. Odds ratio is probably most homogeneous, than even better than risk ratio. But the problem with odds ratio is that it is difficult to make clinicians and much more difficult to make patients understand. Risk ratio is more interpretable, certainly by clinicians, and then can be translated more easily to patients. So you can see here, we have done two meta-analyses, one using risk ratio, the other using odds ratio. So how much is I square? I square is a measure of proportion of heterogeneity in proportion of between study variance as compared to total variance, so 64%. Whereas in odds ratio, 36%. So if you take a cutoff of 50%, which some people use, that more than 50% means it is too heterogeneous, then risk ratio will not be acceptable. Same data, you can just see exactly it is the same data. Same studies, same numbers, but when you use odds ratio, it gives less heterogeneity. So you will feel more comfortable, right? So then you will be tempted to use odds ratio, but actually, as I told you, not easy for clinicians to follow. Yes, whenever heterogeneity is very high, then you should explore causes of heterogeneity. I was telling you about this, that students, I am surprised to see that everybody has forgotten it, so let me repeat this. Students' union complains to the dean, there has been problem with exam results. Some students who failed were actually good, some students who passed were not good at all. So dean appointed a committee to examine whether actually there is a problem, and if there is a problem, then investigate the problem. The exam was like this: written exam full marks 100, practical full marks 100, oral full marks 100. Pass marks was 50% in total overall. So the committee, they looked at marks of each student across 3 exams, written, practical, oral. They found that these students fall into 4 patterns. 4 patterns were that, and remember, each pattern belongs to a certain number of students, not one student. And the figures given are, you can say, mean figures, which, and there is variation of plus minus 5 around that. So some students got 55, 60, 65. So overall 180, 60% pass. Pattern 2, some students got 15, around 15 in written, around 17 practical, around 18 oral. So 165, 55% they pass. Pattern 3 was all around 40, 45, 35. So they got overall 40% failed. And pattern 4 was 90% in the written, 20% practical, 15% oral, 135, overall 45% they also failed. So I had asked you, is there a concern? And everybody said there is a concern. So where is the concern? Pattern 1, who thinks there is a concern? Raise your hand. Pattern 2. Pattern 2, who thinks there is a concern? Everybody thinks so. Pattern 3? Nobody. Pattern 4? So pattern 2 and 4, everybody is concerned. So why are you concerned in pattern 2? Anybody can tell me? In. Discrepancy or disproportionate or inequality or dissimilarity, right? Right. In pattern, so what could have happened in pattern 2? No. Why people, some people who got 15 in written got 70 or 80? Why it could have happened? No. They didn't get good in written. They got only. No. They didn't write well. They got only 15%. No. I'm talking about pattern 2.
Common problem.
Expression comes in written or oral? So oral they have got good marks. I am talking about pattern 2.
They are not expert in written exam. Maybe practical questions are set.
No, you are talking of pattern 2 or not? Pattern 2. Pattern 2 they did very well in oral. As they don't write well. And writing is poor.
Question paper might be extremely tough.
No, it is the same question paper across all the students, right? Influential people, right? So I told you last time that in some country they told me that these are professors' students. So those who are professor, they can think about it, right? So their children, even if they are not doing well in written, they will get good marks in practical and oral and they will pass, right? But I told in that country, I told them that this doesn't happen in India, right? And they were all smiling, right? Pattern 4, what is the problem? They can't speak very well. That's what you mean? Center could have been managed. This was in one center only, so this could not have been managed. Of course, different rooms were there, right? So whatever it is, when I showed this in another country, they said, some students are close to the question setters. And I have seen that they were sitting in a mall one day before the exam. They were all around the table taking some snacks. And suddenly that teacher has told them the questions. So they got good marks in written, but they are actually poor students. They can't perform any practical. They can't speak. So they didn't get it. Any another interpretation of this? They never went to the practical class. That's what Dr. Ganesh said. They are good in theory because they sit in their room and study. Don't go for practical, so they don't know anything about practical. Any other? Expression is poor, yes. Expression is poor, no doubt. Which school? I don't know which school is that. But another explanation they said is these were the students' union leaders who always complain against the professors. So they have shown their power in this, that theory they did very well, they were good students, but in written and practical, they got punished. So that these are the...
So online, Dr. Sandhya suggests for group 4, personal grievances could be the reason.
Personal grievances. Yeah, that's what I'm saying, no?
And for group 2, she says probably the question was out of syllabus.
Question was out of... The same questions were given to all the students.
So it's not possible.
Right? So all the 4 patterns went through the same question paper. Anyway, any other input? No. So anyway, the pattern 2 and 4 are not acceptable because of dissimilarity. And I told you last time, similarity can also be said homogeneity, and dissimilarity heterogeneity. So similarity gives you comfort, acceptability, and that is what in meta-analysis happens. If there is an effect measure which gives homogeneous results, you tend to prefer because of that acceptability. So combining becomes acceptable if there is homogeneity. Need to investigate if there is heterogeneity, or you may sometimes abandon doing meta-analysis. Even if you do it, then downgrade the quality level of evidence. So this is we look at homogeneity by different methods, but I'm not going to go into details of this. But certainly 50% and above is unacceptable degree of heterogeneity. At least it requires exploration of heterogeneity. This is one of our own meta-analysis where how much is the I square? Anybody can read? 11.6%. So that is will be considered homogeneous. Now 50% I said, na? I square 50%, up to 50% less questions are asked. But even if it is more than 50%, you should use your eyeball and look at point estimates, whether they are close to each other, look at confidence intervals overlapping or not, before you conclude that there is heterogeneity. Sometimes these numbers may be different from what inspection will suggest, in which case you should not completely abandon what you are inspecting. So many meta-analyses report odds ratio, but odds ratio is difficult to interpret and difficult to understand and apply in practice. So it also shows overestimation of treatment effect. And this overestimation of treatment effect is exaggerated if event rate is more than 20%, even in randomized trial. So I think we have done this exercise. If there is India winning against Pakistan, odds is 4:1. That means how much chance of India winning? Odds is 4:1. 80%. Yes, that means if there are 5 matches, 4 chances of winning 4, chances of losing 1. So if you do that for all the different 4:1, 3:1, 2:1, then convert that into percentages, and you see in decimals, when do they become close to each other? The second and the fourth column, you can see that they are very close to each other. Last one is exactly same, no? Last line, second column, 0.01, 0.01. So odds and probability become very similar when event rate goes down, down, down. But when did it become close to each other? I would say when it is 1:10, it is 0.1 and 0.09, right? Even 1:9, it is 0.11, 0.1, very close, right? So when it becomes less than 10%, odds and probability become similar. That is the message I want to give. And similarly, odds ratio and risk ratio, they are similar. As you can see, when probability of outcome event is 10%, 0.1 means 10%. It also depends on what is the relative risk. This holds true up to relative risk of 2, right? Beyond that, it starts diverging. So this is, but the question is, which one to choose, risk ratio or odds ratio? This is what we are talking about, or risk difference. So we said, choose a ratio. Which ratio? Risk ratio or odds ratio? This is what we are talking. Odds ratio is there, again you see, risk ratio gives you a summary estimate in this meta-analysis of, can you read it? Risk ratio, how much is the summary point estimate? 0.89. So if 0.89 is the risk ratio, or this is also called relative risk, then relative risk reduction will be 11%, right? Relative risk reduction will be 11%. And I square is 0. There is no concern about heterogeneity. Odds ratio also I square is 0. But how much is the odds ratio summary? Summary estimate? 0.67. So odds reduction, relative odds reduction will be 0.33, which means 33%. So what is 11% there? Same data. And it becomes 33% here. 11% reduction, 33% reduction. So if you are a drug company and you want Dr. Jayaprakash to do meta-analysis, you will also tell him that use what? Odds ratio. So that at the end you will say there is 33% reduction, right? You don't like 11% reduction, isn't it? Now you may think this is only theoretical. This is exactly what World Stroke Association was asked to say by the company, I think. They didn't say that company has told us, but they said that TPA is alteplase, which is used for thrombolytic, as a thrombolytic agent. In their website, big box was there, there is 33% reduction in death or disability, right? So some of us objected it, and then they changed it also because it unnecessarily inflates the figure of effectiveness. So what I mean to say is odds ratio has some problems. It has some advantages, but more problems. Therefore, whenever possible, use risk ratio. This is why Cochrane handbook also says that first thing is that you use unfavorable outcome. Recommends using unfavorable outcome. Like here, this is about people who had unfavorable outcome. If you make it favorable outcome, then it will become much more. Odds ratio will exaggerate much more, right? So use unfavorable outcome because that also tends to give more homogeneous results, and use risk ratio rather than odds ratio. The more consistent the summary statistic, the greater is the justification for expressing the intervention effect as a single summary number. So I told you more comfortable, more acceptable, more justifiable, right? So that is why you use ratio, and in the ratio you use risk ratio. Like when we use outcome of stroke, we say MRS, modified Rankin scale. 0 means complete recovery, no symptoms at all. 1 means mild symptoms, but can do all previous activities without any support. And 2, 3, 4, 5, 6. 6 is death. So it goes on increasing. So generally people take a modified Rankin scale 0 to 1, which is a favorable outcome. They don't use 2 to 6, which is unfavorable outcome. And that may create problem. As you can see, the values of ratio measures of intervention effect, odds ratio, risk ratio, rate ratio, hazard ratio, usually undergo log transformation before being analyzed. Remember I told you 10, 100,000, 10,000, you do log transformation, it becomes 1, 2, 3, 4. So they also do log transformation, and they may occasionally be referred to in terms of their log transformed value, log odds ratio, log risk ratio, and so on. And the graph, the meta-analysis graph represents the ratio scales, sometimes in log scale, sometimes it converts into natural scale. So, but if there is very low event rate, 0 for example, in both the arms, then you can't calculate odds ratio or risk ratio. Peto odds ratio can work if there is a 0 event in one of the arm. But if both arms have 0, then you can't calculate risk ratio. You can't calculate odds ratio. Then what do you use? Then risk difference can be used, right? There are some problems with risk difference also, but we did use it. We did use it in one of our meta-analysis. This is based on risk difference because you can see study number 3. Study number 3, Filali, 1993. 0 by 1, 0 by 1, 0, 0 events. Similarly, you can see last study, Steele, 1983, 0 out of 5, 0 out of 3. So 0, 0 in both the arms. No event. In this situation, you can't use odds ratio, can't use risk ratio, but you can use risk difference because you can calculate confidence interval around that. You can't calculate confidence interval around risk ratio, odds ratio. But it was so homogeneous, I square of 0%, that we were very comfortable in adding it up. And therefore, one should not go with the idea that always the risk difference gives larger heterogeneity. Sometimes it is the only measure which can be used. If you do it like risk ratio, then you lose all the studies with 0 events. It will not calculate. This is same software. You can't calculate. Because this is what I am telling you, no? That when there is 0 event in each arm, then you see what is happening. If you don't use risk difference, use risk ratio. Then how many studies? 1, 2, 3, 4, 5 studies have been lost. Not. Then you can use P2 odds ratio, but not Mantel-Hansel or otherwise risk ratio. You can't use even with 1, 0. But here you see, you have lost so many studies just because there was 0, 0, 0, 0 in both the arms. So all the efforts which you did in collecting the study, evaluating the study, means critical appraisal, all is lost in this. And you also get such a wide confidence interval, 0.49 to 1.67, which means third generation cephalosporins compared to conventional antibiotics in case of bacterial meningitis, community acquired bacterial meningitis, may be as much as 50% or 51% reduction in risk to 67% increase in risk. This is meaningless. But if you go to the risk difference, it says, look here, both are practically similar. It may be 2% less with cephalosporins, but very unlikely that there will be difference of risk more than 14 to 18%. So you get little more convinced about similarity of effects between the two drugs. Now, if it is continuous outcome, then you use you can use one of the two measures, either mean difference or standardized mean difference. So I should tell you, when I started doing meta-analysis, first version of RevMan, and second version, and third version, and fourth version, I think many versions, they had called weighted mean difference, WMD, and standardized mean difference, SMD, right? Because when you use continuous outcome, let's say HbA1c, HbA1c is you are doing some intervention, maybe patient education. So you always took those patients who had HbA1c more than 8%. But when you educated them, let's say they all came down to 6%, 6.5%, 7%, 7.2%, something like this. You take out average of this. In the control arm, they remained around 8%, 8.5%, 7.5%. You calculate average of this. So at the end, when you report your study, you will say average of HbA1c, mean HbA1c was 6.5% in the intervention arm, in the patient education arm, and it was 7.5% or whatever it gets, 8% in the control arm. So you will report mean HbA1c in one arm, mean HbA1c in another arm. So when you do the meta-analysis, you calculate in each study how much is the difference in the mean. This is what you will calculate. So mean difference is 1%, 0.5%, 2.5%, and so on. several studies will give you different percentages. That mean difference, then you will take a average, right? So we always take weighted average. We have discussed that. So it will be weighted mean difference. Mean difference of each study, then you summarize, you take weighted mean difference. That is why Cochrane, Rebman used to write weighted mean difference. But then some people said, everything is weighted. Then why don't you write weighted risk ratio, weighted odds ratio? Even standardized mean difference is also weighted. So you write weighted standardized mean difference. Then the Cochrane people realize that, yes, this is a foolishness. So they removed the word weighted. Now they only write mean difference, right? And standardized mean difference.
अगर पेन दो पेन स्कोर मान लीजिए एनआरएस पेन स्कोर है वाक पेन स्कोर है जो दोनों में से 0 टू 10 स्कोरिंग करते हैं तो डेटा तो आपका कंटिन्यूअस रहता है तो वहां पे केवल स्टैंडर्डाइज्ड मीन डिफरेंस से काम कर जाएगा इफ सपोज दैट वी आर कैलकुलेटिंग पेन स्कोर एंड वी आर गिविंग स्पेसिफिक पेन एंड वी आर गिविंग ओक्वायर पेंटानिल का सर माइक्रोग्राम में डोज होता है मॉर्फिन का एमजी में डोज होता है साइक्लो का भी एमजी में होता है अगर हम यूज करते हैं तो कुछ केस में क्या हमको यूनिफॉर्म स्केल सेकेंड लाइन कन्वर्ट करना जरूरी है क्योंकि बीएमसी का आर्टिकल बोलता है यू कैन कन्वर्ट बाय दिस बट यूएस का जर्नल बोलता है कि यू नीड टू कन्वर्ट
No, that is, you are talking about dose of the intervention, right? But when we are summarizing the effect, dose is not the effect. As a result of the dose, there is some effect. So question you should ask is, how are you measuring the effect? The effect, you may use the same scale, like visual analog scale in every study. So there are 5 studies, these 5 people have done. All 5 have used visual analog scale. So then there is no problem. You can just combine, you can find out what is the mean in this mean score in this study, mean score in that, in the 2 arms, then take a difference between the mean. So mean difference, then you mean difference and then you take weighted summary of that, which is mean difference, and that will be the summary. But if he is using visual analog scale, the other one is using different scale, somebody is using neuropathic pain scale, somebody is using different scoring system, then question comes, how do you combine these? Like, I think you remember I gave example of, if you ask people to do breathing exercises and see how much is their exercise tolerance improving. Now there are 3 studies. Some person has used how many steps he can climb. So he is using step test, right? How many steps he can climb. And take the difference between control arm and intervention arm. How many? That will be number of steps difference. That will be a number. The other person uses force vital capacity in a respirometer. So then he will use in milliliter, isn't it? The third person, he may say cycling. He will use in minutes. And fourth person may say you walk as long as you can. He will measure in meters. So 4 studies, 4 different scales. Now, how do you combine this? This is the question, right? In that situation, you have to convert each scale. Remember, I don't know whether you know, when they do computerized test, NEET, UG, PG, now Central University admission test, you know that each different dates, they give different questions. Now all questions, every day, questions are not of the same difficulty. Then do you know how they make it uniform? So what does the system do?
The person who attempted difficult question won't be correct. the weightage of the marks was very more. And the number of students who attempted the easy question.
No, that whatever questions you will give, they will attempt. No, they can't be penalized for getting on day one when the questions were easy. I don't know how they do it, but what you can do is you can plot the graph. These marks will follow a normal curve, bell-shaped curve, right? Bell-shaped curve means you can describe the whole distribution of marks by a mean and standard deviation, right? So if I have got 50 marks, let's say, that may be in the mean. You got 60 marks and 10 is the standard deviation, right? This is one exam. Second exam, overall mean is 25. It was so difficult question, right? So he is 5 marks away from, 5 is the standard deviation. He is 5 marks away from 25. So is he not same as you? You are 10 marks away from the mean. 10 marks is the standard deviation. So one standard deviation away from the mean, above the mean. He is also one standard deviation away from the mean. Isn't he of the same caliber? At least this is how one of method of standardization is. That for each date you calculate a graph and express everybody's marks in standard deviation units. Right? He is one standard deviation above, he is right at the standard deviation, he is 2 standard deviation. So express it in, so the 60 marks will be expressed as one standard deviation. And 25 marks will, 30 marks will also be expressed as one standard deviation. So they will become of the same, category, ranked. So this is, I don't know what they use it, but this is one way of express everybody's marks in a standard deviation unit. Same thing you can do in these different scales. Express everybody's performance or every study result in standard deviation units. Divide it by standard deviation. This is the beauty of continuous outcome. Na? So, whether you use steps or you use seconds or minutes or you use meter or kilometer or whether you use milliliter in force vital capacity, all can be converted into standard deviation units. And then you can combine it. That is what is called standardized mean difference. Right? Difference in mean outcome between groups divided by standard deviation of outcome among participants. So there is a systematic review which did it. This is also, this is one of our standardized mean difference is the outcome which has been used. I think that's all. Thank you very much. If there are any questions, please. And you ask in English so other people can also understand.
We are giving analgesia and we are giving that most of the drugs we are giving in milligram. And suppose that if we are using narcotics and we are giving in microgram, because fentanyl generally we are using in microgram and morphine we are giving in milligram. So is it necessary to convert that microgram into, because there is one article I read that where it is clearly mentioned that by this reference also quoted, ki by using this rule we converted in that one. So I discussed with Amit, he said no, it's not, no, there is no need to convert in same unit because you are using.
The question is, if you are using the same intervention in all the patients, and we are talking about meta-analysis, na? We are not talking about, we are not talking about converting dose so that we can give equivalent dose to 2 patients. We are talking about what is the effect of analgesia.
Yeah, in one study they used different opioids, in other study they used different opioids. So I 8 study.
But our aim is not to measure weight of opioid. Our Our aim is to measure improvement in pain. Right?
But it was not given. It was given first rescue analgesia and dose was given. That is the problem for.
That, of course,
No,
that is, if that is the outcome, and outcome is milligram or weight of the dose which is required in the rescue medication.
I will.
Then you have to see from literature what is the
I will send you mail.
equivalence. What is the equivalence between the? No, it may be that dose of rescue analgesia is the outcome. If that is the case, then you have to convert them into same. Otherwise, you use standardized mean difference. No need to convert. You are using standard deviation unit of the same measure. No need to convert. You are converting everything into same unit, standardized deviation unit.
I will send you the result also. I will mail you. Please see that.
Okay. Any other question? Any question in the chat box? Okay. Thank you.